It is my honor to give you this presentation on COVID-19 and obesity, the interrelated pandemic. What have we learned in the last weeks? So this is my conflict of interest, and there is no conflict regarding to this presentation. So we know from data from the United States that nearly 50% of people with COVID-19 that were hospitalized were with obesity, a very high percentage of obesity in those patients. And we know from the epidemic of H1N1 in 2009 that obese and severe obese patients were in a very high risk of death because of obesity. And it was not related to any other chronic disease. Just by being obese, they were very high risk to die from H1N1. So we learned from this that obesity is a high risk situation or high risk factor for dying for viral disease. Very recently, again from the States, data that showed us that obese and severe obese is a risk factor for admission to hospital and admission to ICU. But it was related only to age below 60. Above 60, obesity wasn't a risk factor for admission to hospital and ICU. But again, obesity was a risk factor for admission to ICU in the age lower than 60. A cohort from France showed us again that obesity was related to intensive mechanical ventilation compared to non-invasive mechanical ventilation. And in this phenomenal work, they showed us that the higher the BMI, the higher the risk to be ventilated. And nearly 90% of patients with BMI of above 35 were intubated in this cohort. And in a multivariate analysis, again, we see the same numbers that we saw before for the H1N1, that grade 1 obesity were 3.45 risk for mechanical ventilation, and grade 2 or 3 of obesity, meaning BMI above 35, were 7.5 high risk, or odds ratio for 7.35 for being intubated just by being severe obese patients. So obesity is not just a risk for hospitalization, it's also a risk for mechanical ventilation. What we see here is another cohort for the United States that showed the risk for mortality in obese COVID-19 patients. And again, we see that obesity grade 1 or stage 1, there is a risk for 6.85 for mortality, and nearly 10 higher risk, 10 high risk for BMI above 35, and again, a very high risk for mortality. So hospitalization, admission for ICU, mechanical ventilation, and death from obesity, it's all related for being obese. So why do obese patients present a worse clinical picture than lean subjects? There are several explanations, and we can see here in this picture that chronic inflammation and compromised immunity, an increased risk of chronic disease, and increased risk for infection, they are all related to be in high risk for COVID-19 or for other viral infection. So let's start to understand why is it. We know that in obesity, we have dysfunctional adipose tissue. And in this dysfunctional adipose tissue, we have inflamed adipose tissue that produce inflammation, a chronic inflammation in the dysfunctional adipose tissue compared to the lean patient. And we can see here in this picture and this slide that as long as the adipose tissue has adequate blood supply, so the inflammation is low. And when there is hypertrophy of this adipose tissue, it becomes necrotic because there is less supply of blood, because there is hypoxia in the adipose tissue. And this hypoxia produces inflammation and produce cytokines like IL-18, IL-8, IL-6, TNF-alpha, and also leptin can be a pro-inflammatory adipokines in this situation. So in these people with obesity that have a dysfunctional adipose tissue, we can find a low-grade inflammation all the time. And we can see also in this slide that in the adipocyte, there is a production of cytokines. So if there is hypertrophy of this adipocyte, and this hypertrophy leads to hypoxia, in these tracks, we can find production of TNF-alpha, IL-6, and MCP1, meaning that the adipocyte produce cytokine in the baseline. And these cytokines are responsible for the insulin resistance. In a very early study that we have done in obese non-diabetic patient compared to non-obese patient, we also find in the peripheral blood a higher level of TNF-alpha and a higher level of interferon gamma. We also find that the anti-inflammatory cytokine IL-10 was in a lower level compared to the non-obese patient. Again, a proof of the concept that obese patients, even without diabetes, have a low-grade inflammation. What about compromised immunity? So we see that in COVID-19, the virus invade the lung epithelium and cause pneumonia and pneumonitis, and in the end, ARDS. But it's also impaired interferon gamma production from natural killer cells, and also impaired neutrophil recruitment. This leads to impaired immunity and impaired activation of T lymphocyte, meaning that there is compromised immunity after infected by COVID-19. You can see also, if we compare it to influenza virus, so again, the influenza virus invade the lung epithelium, and the virus decreased the production of interferon gamma, alpha, and beta. And this decrease cause inhibition of the immunity that really caused to death of the virus. So the virus is very smart and decrease the immunity against itself. So in the first few days, the invasion of the virus into the epithelium is because decrease of immunity. And this decrease of immunity is enhanced in people with obesity. So we have low-grade inflammation and we have decreased immunity that really cause that people with obesity will be more susceptible for infection and more sick and have morbidity and mortality due to the invasion of COVID-19. So the next question is why obese patients potentially are more contagious than lean subjects. So from this study, again, we see from influenza that obese patients compared to lean patients have higher viral load and longer viral load compared to lean patients. And in a very early study that we have done in COVID-19 patients, it took much more time for people with obesity compared to lean patients to have negative throat swab test, nearly 5 days. Again, we proved the concept that in obese patients, it takes much more time to be negative to the swab for COVID-19. So there is several explanations for this, but the main understanding is that obese subjects with influenza shed the virus for a longer period. And maybe for this, we have to isolate more the obese patients. So we are very familiar now in the way for the COVID-19 to invade the cell. So the COVID-19 attach the S spike of the COVID-19 attach the ACE2 receptor, and by the Tamras S2 help this complex is invade into the host cell. So this invasion or this internalization of the virus through the ACE2 receptor caused that ACE2 receptor would not dissolve or would not transfer angiotensin 2 to angiotensin 1 to 7. So the result is that there is much more angiotensin 2 in the body that cause hypertension and harm to other systems like the heart and kidney. Just because the virus uses much more the ACE2 receptor and does not let ACE2 to dissolve or transfer angiotensin 2 to angiotensin 1 to 7. Now, we know from other studies that there is higher level of ACE2 receptor in the adipose tissue, in the visceral adipose tissue, and in the subcutaneous adipose tissue. Another study shows that expression of the SARS-CoV-2 cell receptor gene ACE2 is in a wide variety of human tissue. And again, we can find the adipose tissue here that is one of the highest tissue with ACE2. We can also find the pancreas here, again, correlate with the damage to the pancreas and production of higher blood glucose level. So higher ACE2 in the adipose tissue can lead to higher invasion in adipose tissue or higher viral load in people with obesity and higher adipose tissue. But when you compare adipocyte from obese patient to non-obese patient, we didn't find, or the researcher didn't find higher ACE2 expression in the adipocyte from the obese patients compared to the non-obese patients. But you have to remember that there is much more adipocyte in obese patient than in non-obese patient. And in the end, you have much more ACE2 receptors in obese patients compared to non-obese patients. And in this very recent study that tried to examine the endpoint of mechanical ventilation and death, or death alone, 7 days after admission in COVID-19 patients, what they showed us that the most important predictor of mechanical ventilation and death, or just death, is BMI. Hemoglobin A1C alone was not a good predictor, and glucose level in the hospital was. So BMI and glucose level were the best predictor of mechanical ventilation and death, or just death. Again, stress and expressing again and again that obesity is a very important risk factor for COVID-19 morbidity and mortality. So if you want to summarize the effects of obesity on the outcome, we can see in the left side that obese patients in the baseline have lower FEV1 and FVC and diaphragmatic contractility, meaning lower capacity of the lung, and lower cardiorespiratory fitness and cardiovascular susceptibility to immune-driven vascular effect and thromboembolic effect. This leads to impaired metabolic response. In the right side, we can see all the factors that we showed recently. That means that they have dysregulated immune response via adiposity and via higher viral shedding and viral load. And this leads to dysfunctional immune response and viral exposure. Both leads to severity from COVID-19 infection. So the baseline of obese and the infection of COVID-19 combined leads to higher risk for morbidity and mortality in people with obesity. And another thought about the comparison between people with obesity and lean patients hypothesized that people with obesity have high DPP-4 and low GLP-1. And as we showed, there is lower ACE2 expression and higher angiotensin 2 leads to higher morbidity and mortality in comparison to lean patients that have higher GLP-1 and lower DPP-4, higher ACE2 and lower angiotensin 2 that leads to lower risk of morbidity and mortality. Now, what is the approach to treatment of people with obesity and COVID-19? So the best treatment is prevention. And prevention is based on physical distancing, hand hygiene, and facial mask. And this is very, very important. The other step is healthy lifestyle. So what about physical exercise? In physical exercise, there is notion that intense physical exercise leads to what we call open window, meaning reduced immunity. So intense physical activity in the time of COVID-19 is not recommended. What is recommended is moderate intensity that leads to higher immunity. And again, we can see here, it's the same message. What about nutrition? So nutrition, we know from animal study and also for human study that high fat leads to increase in ACE2 expression, and higher ACE2 expression may lead to higher viral load. We know also from some studies that low vitamin D is risk factor for worse outcome. We know also that omega-3 can lead to improve in lung function. So low fat, high vitamin D, and high omega-3 and zinc may increase the immunity of people with obesity. What about medication? So we have several anti-obesity medication or obesity pharmacotherapy in Europe, meaning orlistat, liraglutide, and naltrexone bupropion. And I want to concentrate in liraglutide just because liraglutide is the most effective drug for weight loss compared to the other two. So there is some studies in animals that shows that if you give GLP-1 to steptomize type 1 diabetic rats, you increase the expression of ACE2. And you also decrease the expression of angiotensin 2, that we want to decrease it, and you increase the expression of angiotensin 1 to 7 that cause vasodilation and cardiac protection. So the end effect of this liraglutide treatment in this animal is heart and lung protection. In another study, we can see that treatment of liraglutide is increasing the surfactant in pups of mothers that were starved. So mother of pups in food restriction that were treated with liraglutide had much higher, the pups had much higher surfactant, meaning much higher lung protection from food restriction. In another study of in human of people after bariatric surgery, treatment with exenatide really reduced all the cytokines in the adipose tissue that have been taken after the operation. So we can see that exenatide treatment reduced IL-6, IL-8, and TNF-alpha, all the cytokines that relate to the cytokine storm in the obese patients that were infected by COVID-19. In the same study, when they took the adipose tissue from those post-bariatric patients and they caused inflammation by LPS, again, treatment of those adipose tissue with exenatide reduced the LPS infected cells or cause inflammation. So we can see here that the cytokines, the IL-6, was reduced just by treating xanthine-4, those LPS activated adipose cells. So maybe we can conclude that higher GLP-1 in those obese patients may lead to lower inflammation reaction, but this is just hypothesis that should be really proved. The other part of the treatment is the stakeholders part. We have to avoid the stigmatization of people with obesity that were infected with COVID-19. We have to really take care of obese patients with COVID-19 with vaccination, when we will have vaccination, and we have to prioritize treatment for people with obesity and COVID-19 or influenza because of those results that showed us that people with obesity are much more susceptible for morbidity and mortality from those pandemic. And for this study, we can see that people with obesity have much shorter immunity memory after vaccination compared to lean patients. So vaccination for people with obesity has to be prioritized and has to be checked after a while to see if they are still immune, because they have much shorter effect or much shorter memory of this immunization. So if I want to summarize this talk, and my take-home message is that people with obesity with COVID-19 disease have higher risk of hospital admission, mechanical ventilation, and death. Potential explanation for this risk is chronic inflammation, compromised immunity, and increased risk of chronic other disease like cardiovascular disease and diabetes and lung disease. People with obesity with COVID-19 disease may shed the virus for a longer period of time. The high expression of the SARS-CoV-2 cells receptor gene ACE2 in adipose tissue can explain the higher viral load and morbidity in people with obesity. Treatment approach of people with obesity with COVID-19 includes physical distancing, hand hygiene, facial mask, moderate, not intense, physical exercise, sleep hygiene, very important, and low-fat, low-sugar diet, higher vitamin D, higher omega-3. In an animal study, GLP-1 analog reversing right ventricle hypertrophy and improving the production of surfactant in the lung of type 2 diabetes patients, type 1 diabetes rats. And in human study, GLP-1 analog suppressed cytokine activation in adipose tissue of post-bariatric patients. And by summarize this, I want to thank you for your attention. Thank you.
Thank you very much, Dror. That was excellent. We don't have too much time for questions, but I think some of the questions that have been asked we can address at the end of the sessions when we'll have time for discussion. So maybe I'll just ask one question and then add another. One question was, Dror, you mentioned vitamin D. Do you recommend now that the population starts taking vitamin D routinely, and if so, at what dose?
So what we are finding now when we are checking vitamin D to all patients pre-surgery, pre-bariatric surgery, is that almost all the obese patient has lower vitamin D. So lower vitamin D by itself is a risk factor for other disease. And there is studies that in SARS-CoV-2, lower vitamin D is a risk factor for higher infections. So I would recommend to add vitamin D to obese patients as general, and especially to those infected by COVID-19 or are preparing to the pandemic. Usually we said that patients after bariatric surgery has to take at least 3,000 units per day. And for people not preparing to operation, around 2,000 units per day.
Another question was asked whether the obesity is a risk factor for COVID-19 similarly in men and women. Is there a sex difference?
So I can't answer this only, I can answer this only from our data. And in our data that I showed you on the negative swab on the healing from COVID-19, we didn't find gender difference. But we will have to see in the large data on intubation and mechanical intubation and mortality, the gender difference, which I didn't see in the big study yet. We didn't find.
Okay, I think that I'm not sure that we have. Let me just check quickly whether we have time quickly for a short. There are a number of questions here about specifically tackling obesity, but at this time, would you say that medical intervention or bariatric surgery should be encouraged now because of the COVID-19 pandemic?
You mean in the time of pandemic or generally?
Well, yeah, now to try and help people who are obese. I mean, should they be treated vigorously right now? The ones that have not yet been infected.
Yes. So I will divide my answer into two. So in the COVID-19 area, I think there is agreement not to operate those patients because of the resource of the health or the hospitals. You need to have the ICU open and to receive patients from COVID-19. And I think it's not logical to operate patients in hospital or in an environment that increase them to be infected by COVID-19, because it's an operation that you can do every day. But I think the issue is that the problem of obesity has to be recognized, because in most of the country in the world, obesity is not a disease. Okay, people cannot go to bariatric surgery very easily. So what we want to raise the awareness of obesity as a disease, and it's a very high risk factor for this pandemic, not just COVID-19, also for influenza, as I showed you. So obesity as a general is a very high risk factor for a viral infection. And of course, in the treatment protocol, bariatric surgery for those patients is an excellent tool for the patients that are really adequate treatment by the bariatric surgery. So there is two sides of the coin.
I think we have time again for one quick question. How do you define obesity? When you talk about obesity, which category are you talking about?
It's again a very quick question, not relating to the COVID-19, but in all the statistics and the epidemiological studies, BMI is a definition, meaning BMI over 30 in Europe and United States, and BMI over 25 in Asiats is characterized as obesity. But we know that BMI is a very weak measurement of obesity, because you have to define the function of the adipose tissue, meaning, as I showed before, if you are obese and your adipose tissue is functioning and you don't have low-grade inflammation, so maybe you are heavy, but you don't have dysfunctional adipose tissue. And even if you have BMI of 25 and you have dysfunctional adipose tissue, you are obese. So epidemiological studies use BMI, and I think functional study using adipose tissue functioning. But obesity is defined by BMI over 30 or BMI over 25 in Asia.
Somebody asked a question that perhaps they thought that the number of adipocytes was not higher in people with obesity. It was more related to the fat content.
It's true, because there is a long story of debate if obese patients have hyperplasia of the adipose tissue or hypertrophy. So if you have hypertrophy, you have the same numbers of adipocytes. But if you have hyperplasia, so you have higher number. But I accept this correction.
Okay.